everyone. Welcome back to Pain Points. I'm Dr. Jay Caylor. Thanks for joining us today. We're going to be talking about spinal cord stimulation, and this is the long-awaited part 2 of part 4 of 4 parts that we'll be working through when we discuss spinal cord stimulation, which is a neuromodulation technique for chronic pain as well as other therapies. So thanks again for joining us. I'm out of Austin, Texas. I'm a specialist in interventional pain, advanced therapies, as well as cancer pain management, and spinal cord stimulation is something that I feel like deserves a lot of attention and really needs to be done correctly. So as we discussed last time, we're going to be talking about a quick recap today on what is spinal cord stimulation, what is it for, who is it for, and really what's the process of spinal cord stimulation. That'll be a very brief snippet today. And then we're going to be talking about the 3 ways spinal cord stimulation works. And why does it matter? Because spinal cord stimulation is not a pain blocker. I repeat, spinal cord stimulation is not a pain blocker. So we're going to be talking about the first way spinal cord stimulation works, and that's the GABA pathway. The second way spinal cord stimulation works, the serotonin and norepinephrine pathway. And the third way that spinal cord stimulation works is the powerful anti-inflammatory effect. These are the 3 ways spinal cord stimulation not only covers pain up, but actually treats pain. And I think that's one of the things that's fundamental, because most of the time when I'm talking to patients about spinal cord stimulation, they think this is a pain blocker. It's just going to block all my pain, and my pain, my biological processes are just going to continue on. My arthritis is going to get worse. My spinal stenosis is going to get worse because I can't feel the pain and I'm going to hurt myself. That's not true. What we're doing here is actually treating spinal cord stimulation. Now, these are the 3 ways that spinal cord stimulation works. But I think what's most important to recognize here is that spinal cord stimulation actually works in a number of other ways that we don't know about yet. We have some preliminary data that might suggest some other mechanisms of action, but these are the way that we know it works. So that's the exciting aspect of it. So thanks for joining me today as we learn about spinal cord stimulation and how it works. Not a pain blocker. So what is spinal cord stimulation? Here on the right side of the screen, you see a spinal cord as if it had been taken out of a patient and laid on the table. Now, traditional spinal cord stimulation is some wires, and those are the little wires you see laying on top of the spinal cord. And on those wires are multiple contacts. And those contacts are hooked through a wire to this thing on the right side called the IPG, which is the implantable pulse generator. Now, what this does is it sends a pattern of electrical pulses into the spinal cord, creating an electric field that reprograms the pain sensation. And that's really, really critical. So what is spinal cord stimulation? It's a pattern of precise, calculated electrical pulses that fundamentally change the interaction between the brain and the spinal cord. Not a pain blocker. We construct an electrical field, and it's this electrical field that actually causes real biologic change. So it's not a pain blocker, if you haven't guessed a theme here. So what we're doing is using these pattern of electrical pulses to create an electrical field and change the way those neurons are interacting between our body and our brain. It's not a pain blocker, if you didn't guess. So that's spinal cord stimulation. Remember, there's a couple parts to a spinal cord stimulator trial and implant. The first part is the trial. That's the test run. That's the try it before you buy it. And what we're doing during that 7 to 10 to 14 days is putting some temporary wires on the spinal cord, just like this guy right here, and we're actually giving it a shot. For lack of a better word, we're trying this sucker out, and we're going to see, can we reprogram your spinal cord and actually improve your chronic pain? The second part of that is the implant, and that's the exact same thing as the trial. We put those wires, we use everything we learned about you with the trial, and we just place this tiny little battery, and that's the IPG on the right side. That goes under the skin somewhere in the back or upper buttocks, and we connect that to the wires, and that's how we get long-term pain relief. So that is what spinal cord stimulation is. Now on to how spinal cord stimulation works. So spinal cord stimulation works using a pattern of electrical pulses, and what we're doing is creating real change in the body. Here's an example of some contacts on the right-hand side of the screen. You can see that using positives and minuses, these are cathodes and anodes, actually switched there. But what we use this pattern of electrical pulses on multiple contacts to map out areas of coverage for the patient. And then from that, we can apply electrical waveforms to cause the change we want to see in the spinal cord. So now we're on to actually how does spinal cord stimulation work. So part one is the GABA pathway. And the GABA pathway, actually what it does is with spinal cord stimulation is it actually increases the amount of GABA in the spinal cord. Now, what is GABA? GABA, you've probably heard of the other GABAs, and that might be the gabapentin or the pregabalin, that's the Lyrica for you, or the Neurontin. That's not the same GABA. That's a different GABA. Okay, so that while you might say, I tried that didn't work. No, those are different GABAs. This is GABA, a principal neurotransmitter in the spinal cord that's essentially like a neuronal stop sign. You take GABA, boom, you got a stop sign. And that's what we're doing with spinal cord stimulation, is we're using that GABA pathway to say stop. We don't need that pain signal. For everyone that's on gabapentin and pregabalin, not the same. GABA is a neurotransmitter, and it's the brakes of the operation. And just like we need neurons that do things in our brain, we also need neurons that stop things in our brain. That's how this crazy circuitry that's our central nervous system works. So let's say you get some pain, and here on the slide we have a pain source. That might be a flame on top of a match. So you got a pain source coming out here in the hand. What has to happen? Well, you might remember from Pain 101, you got a primary neuron, and essentially what's going to happen is that pain signal goes to the spinal cord, and it's going to make its way up into the brain. And that's how we sense pain. So a nerve carries that signal into the spinal cord. It connects with another nerve through some fancy magic and sends that sensory signal up to the brain. We experience pain. There we go. Now, once that pain signal is getting into the spinal cord, I wanted to zoom in and actually show you. This is what you see in the spinal cord, because we think it's just some fancy magic, but we actually know what's going on. And so I want to talk about a little neuron here called the pain signal. And I know you're thinking at this point, Dr. Caylor, you told us we were done with pain pathways. We are done with all these little neurons and all this. And I'm so sorry, because here we are back again. But in order to tell you how spinal cord stimulation works, you got to see this. So what happens with a pain signal is we get a pain source, and that pain source comes into the spinal cord, and it's going to go through this little interneuron, that's the blue thing, and pop up the other side and then go to the brain. That's a standard 3 interneuron circuit. And there's a whole bunch of other control and complexity here that I just threw aside. So if you're an MD or a PhD out there and you're saying that's not how this works, that's correct, but this is the principle of it. There's a lot of controls, and this little blue guy here is the interneuron, and he's the principal kind of neuron in figuring out, is this signal going to go to the brain or is it not? Now, let's talk about spinal cord stimulation and do the same thing. Well, I already told you that GABA is the brakes of the whole outfit. Well, the interneuron expresses GABA, or some interneurons do. In this case, this blue one does. So when we utilize spinal cord stimulation, we might have a pain signal again. So here's our pain source, and that might be from arthritis or nerve pain. But instead of getting its way all the way to the spinal cord, we're using spinal cord stimulation. Spinal cord stimulation increases this little blue guy's ability to block pain signals by expressing GABA. More brakes, less pain. And so now we have this guy doing a nice little 360 saying, no way, you're not going to get any pain past me. And so instead, that signal falls to the wayside. And instead of that signal now making it to the brain, now it's actually being stopped in the spinal cord. So part one of how spinal cord stimulation works is increases GABA. That's a real change that we actually measure in preclinical models, which are all of our experimental studies. This is a real thing that spinal cord stimulation is doing. This is not a pain blocker. This is real. That's our stop sign. No pain signal gets to the brain. Now, it's not no pain signal. That's what a pain blocker is. This is the bad pain signals, the pain signals that aren't doing something. So let's go on to part two, serotonin and norepinephrine. So I know we just spent all this time talking about GABA. Well, what's serotonin and norepinephrine? Well, you might have heard these neurotransmitters as being neurotransmitters that are important in anxiety and depression and being in the brain. And that might be true, but they also work in the spinal cord too, and they're extremely powerful and important. So when we look at what do serotonin and norepinephrine do, they have multiple functions. And in the spinal cord specifically, they're actually important for what we call descending anti-nociceptive control. Now, that's a big fat word, delete the whole thing. That's essentially what we're doing is actually controlling what information even makes it to our brain. And this leads to pain relief and many of the same mechanisms that GABA does as kind of that blue stop sign, as in, I don't need that information. And you can imagine that if you were to bump your elbow or what have you, and you rub it, it feels better. Well, that's actually your brain's recognition that, hey, there is something here that is not giving me any information that I need, so I'm going to suppress that information. And that suppression is serotonin and norepinephrine. It's the same thing that I tell patients. You probably weren't thinking about your left pinky toe until I just told you about it right now. It's the same phenomenon. Your body is suppressing that information because otherwise we'd be on constant sensory overload. So spinal cord stimulation is actually enhancing and utilizing some of our normal things to stop signals that aren't helping our brain. And that's very, very powerful for us. So we have this control. So now we've got this blinking blue ball that's in the brain over here. And what I want you to see is what's going to happen is descending control means that our brain is able to control what information it even sees in the first place. That's the power of our brain. And here you can see that serotonin and norepinephrine are actually critical to being able to create another form of a stop sign. And so if we have a pain signal, such as a flame or whatever, that's going to go to the stop sign. And instead of making it to the spinal cord and actually getting all the way up there, it's going to be blocked. And that's the beauty of what spinal cord stimulation adds to serotonin and norepinephrine pathways. All right, we've gone through the first two. And the first two have been GABA and serotonin and norepinephrine. Three powerful neurotransmitters that are real, that are changing in the spinal cord. We're seeing real changes in the brain with this electrical activity. What's this anti-inflammation that you're talking about? And the first thing that I want to tell you is chronic pain leads to inflammation of the spinal cord. Much like that bodybuilder, if he only did left-sided bicep curls over and over and over again, that left bicep's going to get really, really big. If we have chronic knee pain and that knee pain fiber, that neuron is firing over and over and over and over again, in the same way, that neural circuit can become hypertrophied or inflamed. And that inflammation causes real problems in the spinal cord that we can measure. So there is real inflammation that occurs in the spinal cord. It's not just in your head. It's real changes that we see that we can treat with spinal cord stimulation. And like I said before, spinal cord stimulation is not a pain blocker, but it causes actual measurable changes in the spinal cord. And we see these changes in gene expression. And when we look at the big evolution of spinal cord stimulation over the last 20 to 30 years, the greatest thing that I think we've seen so far is that just like you take steroids by mouth, and that's a very powerful anti-inflammatory, or you get it in injections or targeted therapies, and you get anti-inflammation. We can use these electrical pulses to create anti-inflammation in the spinal cord that doesn't have the side effects of steroids. And that's a beautiful thing. And what we're doing is actually creating a situation where all of the cells, the supporting cast of the spinal cord, are getting this power anti-inflammation to support the neurons. And why does that matter? Now, here's a random picture. I don't want you to look at it or read it, but a neuron has all these tiny little cells that are helping it. And the neurons, their only job is to send information. They're sending information here, they're receiving information here. And over time, if they get overused, they lose all their energy, they become inflamed. All the cells that are around and supporting it are becoming inflamed. And what happens with that inflammation is that you're more likely to make a mistake. You're more likely to send a signal that shouldn't be sent. And electrical stimulation, with these targeted electrical patterns that we're using, can revert that to the normal phenotype, meaning we can actually revert that to look like more like what we would call normal. And you can imagine that if you had a bee sting and there was inflammation, it's not just sensitive right where the bee stung you. No, it's sensitive around that whole area. And that's the same type of thing that happens in our spinal cord. Is when we have a bee sting and it hurts even off to the side, that's the same thing that's going on in your spinal cord. You have injury, and even nerves around it that shouldn't be painful are causing pain now because that central nervous system is inflamed. And that's the power of spinal cord stimulation, is that using this stimulation, we can actually decrease the inflammation that's occurring in the spinal cord itself. And that's one of the really, really cool things that we're able to say as the third, and in my opinion, the most powerful aspect of spinal cord stimulation, is that it decreases the amount of inflammation, not only within the neuron, but the entire spinal cord, so that the signals that are making it to the brain are the right signals and not the wrong signals. If you have any questions at this point, bring them up. I love to hear them. But other than that, I'd like you to join me every Thursday at 12:30, and we'll continue on this journey together. Next week, we're going to be talking about clinical evidence. No, this stuff isn't experimental. Spinal cord stimulation has been around for a long time. And one of the things that's really, really cool about it is that we're learning more about it every single day, every year. We're having new therapies and new waveforms. So one question I got here is, will spinal cord stimulation stop sciatica nerve pain and the signals that go along with it? And the short answer is it depends. And the long answer is also it depends. But I think what the real question to answer your question is what is that sciatica from, and has that pinched nerve been optimally unpinched? Now, when we think about the degenerative process in the spine, so let's say we have a pinched nerve, that damage from that pinching can be temporary, it can be short-term damage, or it can be permanent. And there's different levels of nerve injury. I think spinal cord stimulation is actually truly best for patients that have a decompressed nerve that has chronic nerve injury. And that's one of the things, when we think about this inflammation, that's where spinal cord stimulation is a home run. Now, have I had patients that have had excellent success with lumbar radiculopathy and spinal cord stimulation? Absolutely. And I think the thing that's most important, whether you've had a spinal cord stimulator or you're thinking about spinal cord stimulation, is, do you have a team approach to figure out what's going to happen if we decompress that nerve, or has everything been optimized for you? And then in reality, if we're moving through the spinal cord stimulation paradigms, do you have a physician involved in your spinal cord stimulator care? Because that's really, really important. So short answer, I think spinal cord stimulation can be a very powerful tool for patients with lumbar radiculopathy. But in patients that have an option to have decompression of that nerve root, they can actually do very, very well with a surgical decompression. If you've already been decompressed, or if surgery is not a good option, that's where spinal cord stimulation is really, really powerful. And now I've had patients that continue to have that compressed nerve that they're not good medical candidates for spine surgery. And that's another place where spinal cord stimulation can be really powerful for patients. The importance, in my opinion, is making sure that we remember that nerve is pinched, and that we might need to pivot. And there might come a time with spinal cord stimulation that, regardless of what we do with electrical stimulation, if that nerve continues to be crunched and crunched and crunched, that we might have more of a challenge in that situation. All right, as always, if you guys have other questions, throw them up on Facebook or YouTube. You can catch us there. Throw out other things that you want to talk about. I know patients want to talk about, intrathecal drug delivery or the pain pump, and we're going to be talking about that shortly. You want to learn about headache, you want to learn about knee pain, you want to learn about other types of things that we do or other information that's out there. I'm happy to put it together. So thanks, as always, for joining me. Whether you're my patient or you're just checking us out, thanks for joining and continuing to spread the word about pain and pain education.